Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is a continuing presentation in health assessment, physical assessment in the adult. And in this presentation we're going to be looking at the abdomen. So there are numerous clinical manifestations that relate to an abdominal anomaly, and this could be indigestion, dysphagia, difficulty swallowing, nausea, vomiting, abdominal pain, bloating as a result of gas, jaundice as a result of liver issues, and hernias. When we come to the physical assessment, as far as the abdomen goes, the abdominal examination is to assess for signs of disease, as is with all systems. And the examination typically involves a thorough medical history, as with all assessments. The abdominal examination is conventionally divided and has 4 techniques: inspection, auscultation, palpation, and percussion. Now take note, auscultation occurs second rather than fourth in an abdominal examination. And the rationale for that is, if you palpate or percuss before auscultation, this may alter the bowel sounds. And if it alters the bowel sounds, it may provide misinformation. Now, when it comes to the abdomen, subjective assessment is important. And in addition to that, the focused interview explores family history, medical past, medications, lifestyle behaviours which could put the patient at risk, and symptoms. Symptoms or clinical manifestations could include pain, diarrhea, distension, gas, nausea, vomiting, constipation, flatulence, weight loss, which is unintentional, anorexia, steatorrhea, constipation, pale stools, melena, and jaundice. Some of the signs and symptoms or clinical manifestations related to gastrointestinal disorders could include abdominal pain, constipation, diarrhea, heartburn, which is indigestion, gastrointestinal bleeding, melena, pale stools, steatorrhea, bloating, jaundice, flatulence, nausea and vomiting, dysphagia, difficulty swallowing, anorexia, ascites, renal colic, hematuria, and crepitus. And again, the last 3 really are as differential diagnosis because they could cause abdominal pain as well, or be associated with gastrointestinal system issues. When it comes to the abdomen, the family history again is important. And questions could be related to, do you have a family history of any problems related to digestive system? For example, GERD, gastroesophageal reflux disease, which is fairly common. Peptic ulcer disease, which may also be considered common. Inflammatory bowel disease, such as Crohn's disease or ulcerative colitis. Irritable bowel syndrome, which could be related to possibly lactose intolerance. Anemia, certain blood dyscrasias such as thalassemia, and celiac disease, which is an autoimmune disease in respect to gluten issues. But many of these conditions are genetic, they can be inherited, and they can be autoimmune. When it comes to past or present history, questions could be related to, have you ever had any of the following associated problems or disorders? And note that they can all affect the gastrointestinal system and tract. Food allergies, chewing and swallowing issues, weight gain or loss, alcohol abuse or use, genitourinary issues, and joint pain. Food allergies may result in belching, bloating, flatulence, diarrhea, or constipation. Chewing or swallowing could be related to some sort of endocrine disorder or neuromuscular disorder, which could be, for example here, Parkinson's disease, myasthenia gravis, or If it's thyroid, because of goiter, then probably hypo or hyperthyroidism. Weight gain or loss could be related to cardiovascular disease. It could be related to too much sodium in the diet. It could be related to hypothyroidism or hypothyroidism. Alcohol, excessive alcohol can result in liver disease, which can cause numerous issues related to an abdominal or gastrointestinal tract system. Genitourinary, so therefore you could be looking at urine maybe to eliminate certain issues that may occur. But again, dark urine can also be an indication that there is an issue probably with your liver, hyperbilirubinemia. Joint pain, any autoimmune disorder could be related now to the abdomen. Medication history is also important, and questions that may be related to medications and the abdomen are you taking any over-the-counter or prescribed medications? Because then patients may be frequently taking antacids, which can be received and bought and ordered over the counter. Patients who take non-steroidal anti-inflammatory drugs are at risk of gastric ulcers if taken over a long period of time. Patients who take opioid medications are at risk of constipation, nausea, vomiting, bloating. Patients who take antibiotics are at risk of altered bowel function. Patients who take oral contraceptives are at risk of developing inflammatory disease related to the bowel. As far as the assessment equipment goes, gloves are important. A tape measure, a pen marker, a reflex hammer, and a small pillow is typically used in assessing the abdomen. When it comes to the abdomen, objective physical assessment findings include the vital signs. And the techniques that we employ are inspection, auscultation of the bowel sounds, and palpation. And the rationale for nurses is to evaluate whether the patient is stable or unstable, because vital signs will determine life-threatening or potential life-threatening conditions. Inspection is looking. So you look at the abdominal skin, you look for the contour of the abdomen, any abnormal waves or pulsations that are detected. Typically, you won't see those, but you inspect for size, shape and symmetry, and you note the condition of the umbilicus, whether it's inverted, everted, or whatever its position is in. You assess for abdominal distension, and if present, determine if it's now generalised or only in one area. You ask the patient if the abdomen is different from normal, and you inspect for visible pulsations, which could be related to the aorta, the bowel peristalsis, or maybe even the breathing pattern, and you evaluate for ascites, which is an abnormal collection of fluid in the abdominal cavity. Examples of anomalies could include jaundice, spider nevae, which may indicate liver disease, distended veins flowing away from the umbilicus, such as caput medusae. You can see bruising, which can be in the flank or the groin. Also ecchymosis. This could be the Gray-Turner sign, or you could have periumbilical ecchymosis, which is the Cullen's sign. There can be scars, there can be hernia. When it comes to auscultation of the bowel sounds, you auscultate in all four quadrants. And this is where you place a diaphragm that is not cold, it's been warmed, and you gently place the diaphragm in each quadrant. Typically you start at the ileocecal valve in the right lower quadrant, which is slightly right and below the umbilicus, and you proceed in a clockwise manner. Normally you'll hear 5 to 30 clicks per minute, one bowel sound every 5 to 15 seconds in an irregular, it's not regular, in an irregular pattern. And these sounds indicate bowel motility and peristalsis. Hypoactive bowel sounds or absent bowel sounds may indicate a paralytic ileus, and hyperactive sounds, borrybogamy, are usually present in the small bowel obstruction, but they can be normal when you're very, very hungry as well. If there are no sounds that are audible after listening for 5 minutes, then you can state that they are absent. Auscultation also involves vascular sounds, and you auscultate with the bell over all 4 quadrants. You listen over the aorta in the epigastric region, over the renal and iliac arteries, and you're listening for bruits. Venous hums in the epigastric region over the umbilicus may indicate a partial obstruction of an artery and reduced blood flow to an organ. Lastly, you auscultate over the liver and the spleen for friction rubs. You can look at the diagram to determine the landmarks. When it comes to palpation of the abdomen, you begin with light palpation in all 4 quadrants. The patient is placed in a supine position with the head relaxed and the arms by the side, and your knees or the patient's knees can be slightly bent, being supported by a pillow. But the abdominal muscles need to be relaxed. You press down 1 to 2 centimetres in a rotation motion. You lift the fingertips and you move to each of the 4 quadrants. And while doing so, you always observe for grimacing or gardening, grimacing of the face, which will indicate that there may be tenderness or pain. You also assess for temperature, tenderness, texture, elasticity, moisture, and pulsations and masses, which may be felt as thrills. Then you follow with deep palpation, where you use a single or 2-handed technique to assess for organs and locate masses or identify tenderness. With the fingertips, you depress 4 to 6 centimetres in all 4 quadrants. You place the non-dominant hand on the dominant hand and press down using firm pressure. You can use bimanual deep palpation for a large abdomen, but ultimately you are assessing for shape, size, symmetry, tenderness and mobility. And it's during palpation, again, tenderness should be noted, which may be present by looking at the face, facial grimacing or guarding. Advanced techniques can be now palpation manoeuvres for the bladder. And this is where you palpate deeply in the hypogastric area. The bladder should be emptied and it should be non-tender if empty. And it shouldn't be palpable. A palpable bladder is either full of urine or enlarged from an underlying mass. A tender bladder may actually indicate that there's a urinary tract infection. An advanced technique for liver assessment, you place your right hand in the patient's right mid-clavicular line under the costal margin. you place the left hand on the patient's back at the 11th and 12th ribs. You press upward to elevate the liver towards the abdominal wall and have the patient take a deep breath. When you press the right hand gently but deeply in and up during inspiration, the liver edge is palpable against your right hand during inspiration. But it's not always detectable. Another device or another technique that can be used is the hooking advanced technique. With the hooking technique, you place your hands over the right costal margin, hook your fingers over the edge of the ribs, have the patient take a deep breath and feel for the liver's edge as it drops down on inspiration and then rises up over the fingers on expiration. Difficult for a novice to do and may sometimes not be detectable. When it comes to the spleen, this is another advanced technique. You stand on the patient's right side, you place your left hand, the patient's left costovertebral angle. You place your left hand under this angle and you pull upward to move the spleen anteriorly. You place your right hand under the left costal margin and you have the patient take a deep breath, and during exhalation you press inward along the left costal margin. Try to palpate the spleen, but normally a normal spleen is not palpable. If required, you can alternatively have the patient turn onto the right side to move the spleen more forward. But as I said, typically a normal spleen is not palpable. When you're palpating the kidney, which is another advanced technique, and it's not common to do so. To assess the left kidney, for example, you stand on the patient's right side, you place your left hand on the left costal vertebral angle and your right hand at the left anterior costal margin. You have the patient take a deep breath and press hands together to capture the kidney. But typically, you may not be able to feel this either. As the patient exhales, you lift the left hand and palpate the kidney with the right hand. But this is typically something that you may not be able to palpate under normal circumstances. When you're palpating the aorta, which is another advanced technique, caution is advised because, again, the aorta may rupture as a result of an aneurysm. But to palpate the aorta, place the fingers in the epigastric region and slightly towards the left of the midclavicular line. You palpate for pulsations, thrills, on either side of the aorta. To assess the width of the aorta, you place one hand on either side. Pulsations are palpable. The normal aorta typically measures about 2 centimetres. And an enlarged aorta is greater than 3 centimetres, or one with a lateral palpable pulsation can indicate that there is an abdominal aortic aneurysm. But caution is always advised. Another advanced technique is utilising McBurney's point. Now, McBurney's point is typically 2/3 of the way from the umbilicus to the anterior superior iliac spine of the pelvis. Now, McBurney's point, if tenderness or pain is detected on palpation, then this could imply appendicitis, inflammation of the ileocolic area, which could be due to Crohn's disease, or an infection. or other issues related to inflammatory bowel disease or ulcerative colitis. If tenderness is appreciated at McBurney's point, the following manoeuvres can also be utilised to determine whether it's appendicitis, which could be Rovsing's sign, Psoas sign, or the obturator sign. This is Rovsing's sign. Rovsing's sign is an advanced technique where, while standing on the patient's right side, you gradually perform deep palpation on the left lower quadrant of the abdomen. And then what will happen is this will describe right lower quadrant pain provoked by pressure, palpation in the left lower quadrant, which could indicate acute appendicitis. If the right lower quadrant pain does occur, it's a positive Rovsing sign, sometimes referred to as Perman's sign, which was identified in 1904. Now, increased pain in the right lower quadrant suggests right-sided peritoneal irritation, and this can be a positive indicator of appendicitis. Another sign can be Blomberg's sign, and this relates to rebound tenderness. And this is also known as rebound tenderness, but Blomberg's sign is the proper term. And this is a clinical sign which may be elicited on physical examination and may be indicative of peritonitis. Now, deep palpation in the right lower quadrant is indicated, and what happens is, after releasing or followed by a sudden release of pressure, it causes severe pain in the right lower quadrant. This is Blomberg's sign, which is also known as rebound tenderness. Psoas sign is another advanced technique where you place your hand just above the patient's right knee and ask the patient to push against your hand. This results in contraction of the psoas muscle, which causes pain in the right upper and right lower quadrant. And if there is appendicitis or an inflamed appendix, this will cause pain. The obturator sign is another advanced technique, and it's performed by flexing the patient's right thigh at the hip with the knee flexed and rotating internally. And what should happen is there will be increased pain in the right lower quadrant, which suggests inflammation of the internal obturator muscle from overlying an appendicitis or an appendix that is inflamed or an abscess. The final sign could be Murphy's sign. And Murphy's sign is typically produced in patients with acute cholecystitis, inflammation of the gallbladder. And you ask the patient to take and hold in a deep breath while palpating the right subcostal area or the right upper quadrant. If the pain occurs during inspiration, when the inflamed gallbladder comes in contact with the examiner's hand, the Murphy's sign is positive. Now, anomalies associated with the abdomen could include obesity, bloating as a result of gas distension, and abdominal tumour. It could demonstrate ascites or an acute abdomen, which relates to abdominal pain. It could also include appendicitis. It could also include a potentially life-threatening condition such as an abdominal aortic aneurysm and, as we indicated with Murphy's sign, acute cholecystitis. That's the end of this presentation. Thank you. If you found it of any benefit to you, please recommend it to your colleagues and friends, and please subscribe if you want to be notified of future Dr. Manny Learnshops. Take care and God bless.